So, differential diagnosis in oncology. This is not necessarily meant for the people who've practiced dermatology for 3 decades, but it is meant for some of the others. And so, BCC and SCC is what I'm going to focus in on. Some are easy to diagnose without even having a biopsy, others not. And I'll talk about epidemiology and clinical presentation as well. So, non-melanoma skin cancer, everybody knows this. Most frequently observed malignancy among Caucasians without question, and ultraviolet light, living here in South Florida, or where I grew up in southern Arizona, Southern California, certainly major risk factors. But there are other risk factors as well, whether it's ionizing radiation, arsenic, organic chemicals, HPV infections, immunosuppression, and certainly we're seeing more and more immunosuppression because of all the transplants that are occurring. And surgery, historically, one way or another, has been the mainstay of treatment, but we've got other ways to treat now, and we're going to talk about some of that over the course of the next couple hours as well. So, overall epidemiology, as I said, Caucasians certainly most affected because they have the lightest skin. The exact incidence, everybody talks about the fact that there are just millions and millions of these, but very difficult to obtain these due to the limited state cancer registries. There are certainly state cancer registries in most states for melanoma, but not for non-melanoma skin cancer. And as you know, positive correlation with latitude and average annual ultraviolet exposure. Under 40 years of age, interestingly enough, the majority of non-melanoma skin cancer does occur in women, but after 60 years of age, men take much more of these, leading women 2 to 3 to 1 ratio by age 80. If we look at squamous cell carcinoma, the epidemiology of that, you see more as people get older. Males have more. Previous history of AKs certainly is one of the risk factors. As I said, over the age of 60, certainly a major risk factor. The majority are going to be on sun-exposed areas, so it's head, neck, upper extremities. Mortality certainly is rare, but is more common than basal cell carcinoma. It is certainly higher in whites, as you would expect, higher in older people, as you would expect, and higher in men, as you'd also expect. So men have a 3 to 1 greater SCC mortality as compared to women. In darker skin types, you tend to see more SCC at areas of chronic irritation, scarring, injury, previous radiation therapy. And SCCs on the ear, lip, and genitalia certainly are higher risk factors. Contrast that with BCC, which certainly is the most common skin cancer in humans, more common in males, although more common in females under the age of 40, but still more common in males. And the risk factors are somewhat the same, lighter skin types. Mortality is really rare. So, I run an active Mohs surgery unit in northern New Jersey over 35 years. I've had 2 people who have died from metastatic basal cell carcinoma. They were both farmers who were sent to me in my early career from upstate New York who had basal cell carcinoma, in one case from his neck down to his waist, and in the other case from his left shoulder down to his left hand, obviously ignored for decades, but that's really rare. You do tend to see metastatic BCC with a more aggressive histopathologic pattern, and sometimes there's an element of SCC there as well. Perineural involvement also suggests more aggressive disease, and when it spreads to lots of places. BCC, as I said, more common in males than females, very rarely spreads, and if it does spread, it's usually more locally. Okay, let's see if we can get this thing to work. Guess what? Not advancing. Hello. Hey, guys. Poor guy on the podium needs help. Technical difficulties. Can you advance them for me? It's not going backwards or forwards. Okay. How's the coffee? Yeah, that would be great, but it won't work for this thing. Yeah. Okay. Ah, look at that. Okay. Okay, so, let me go back one. All right, good. Thank you. So as I said, ultraviolet exposure is the major risk factor here for non-melanoma skin cancer. BCC, is a higher risk with intermittent intense episodes of UV exposure. So that's, living in New York, going to the Jersey Shore. SCC with cumulative long-term UV exposure. So that's down here where people get it all the time. There are all kinds of artificial sources now of ultraviolet radiation. Those certainly are risk factors as well. Poo is not around that much anymore, but certainly it leads to a greater risk of skin cancer. Here's some stuff, talk about differential diagnosis. Someone comes in, hands, feet looking like this. I think the initial thought is, eczematous dermatitis, psoriasis, and that's not unreasonable. And then you treat with topical steroids and it doesn't go away. And then you start asking questions, and they've been exposed to arsenic or aromatic hydrocarbons, and these are SCCs arising from chemical exposure. Same thing, immunosuppression. Sometimes you don't think of these skin cancers. This could look like psoriasis, look like an irritated seborrheic keratosis. It could be even look like one of the bull's diseases. But we know that BCC has a risk of 5 to 10 times in organ transplant recipients, and SCC is really even higher than that, anywhere from 40 to 250 times higher with organ transplant recipients. Some of the other factors are going to be the same. Transplant patients who are lighter skinned, who have more sun exposure, certainly have a greater problem. And generally, you tend to see multiple lesions, much more local regional recurrences. They definitely have a higher risk of Mets, and we're starting to see more and more metastases from squamous cell carcinoma, in part because of this population. And that will lead to some of the discussion about genetic testing, which we'll talk about. And so of renal transplant patients, 5% of them die from skin cancer, which did not exist 25 years ago. And it's even higher in heart transplantations. So you've got 27% of patients who have heart transplants actually die of metastatic skin cancer. 2/3 of them, as you would expect, are squamous cell carcinoma. And you look at this thing, and it kind of looks like a relatively benign multiple keratoacanthoma. It's not. And so here again, differential diagnosis. You look at this stuff and you look at that thumb, and you might think eczematous dermatitis, psoriasis. You got to start thinking squamous cell carcinoma. And SCC in situ historically has been called Bowen's disease. It presents as this erythematous scaly patch, sometimes slightly elevated. Rarely do these become invasive, but they're often misdiagnosed early on. You can see that nail. You can see the impact on the actual nail plate by this lesion. Some have even treated some of these as warts before. They're not. Bowen's disease in some strange places. Obviously, fingers can get it, but so can the genital areas, and often these are misdiagnosed by gynecologists all the time. And the same thing with SCC in situ on the penis, erythroplasia of Queyrat. This is often diagnosed as, you name it, STDs, squamous cell carcinoma, psoriasis, something like that. But if it doesn't go away and you've treated it for a couple of months, you got to start thinking other things and do a biopsy. Features of invasive SCC, more common locations such as the bald scalp, face, neck, extensive forearms, obviously areas with chronic sun exposure. They usually are papulonodular, but they can be exophytic and papillomatous. Sometimes they are mistaken for funky-looking seborrheic keratoses because they are hyperkeratotic and they do enlarge slowly. This is more examples of invasive SCC. It'd be hard to misdiagnose some of these. Something's going on. Generally, you're going to biopsy these. And again, invasive SCC in unusual locations. And generally, when this happens, they are HPV-induced. And most of these patients have a long history of human papillomavirus. The SCCs on the lips are definitely a different breed. They're not as serious as SCC on the tongue or in the throat, but they are certainly more serious than SCC on other sun-exposed areas. And then keratoacanthomas are kind of funky. We treat them. They are a variation of SCC, but some of them actually even spontaneously go away, and they're pretty characteristic in their appearance with that dome-shaped lesion. And you can see these KAs occurring on really all the different areas that you would expect to see skin cancer on. But again, the same common predisposition, sun exposure. And so, as I said, SCC is becoming an enlarging problem in the US, and by and large, millions and millions and millions of them are no big deal. But we're seeing people live older, we're seeing people who are more immunosuppressed, and they're starting to have more problems with these. And so this has become a bigger issue because the number of SCCs certainly exceeds those of melanoma, and we've got to deal with all these immunosuppressed cancer patients. And unlike melanoma, breast, and other common cancers, SCC patient care generally has not been evaluated with gene expression profiling, and that is starting to change now in some of these higher risk groups. Because the current staging of SCC, certainly for these more severely identified patients, fails to identify 30% of the people that go on to experience metastases. So, you know, the 85-year-old guy who shows up in my office who's had skin cancers for years, who has an early SCC on his scalp, certainly does not need genetic testing. But you have to start thinking about that for some of the others. So this is the Castle Bioscience, and you're going to hear a lot about this weekend. These tests are starting to become almost the standard of care in our treatment of patients for certain select groups, and that's true for melanoma as well as squamous cell carcinoma, because they take some of these patients. Again, they have to be high risk to begin with, and that's what you're going to look at. But they take some of them, and they can better predict who may end up having problems versus who will not. And papers published on this already, looking at an expert panel of Mohs surgeons, oncologists, radiation oncologists, taking what clearly is a tricky area, because obviously the overwhelming majority of SCCs are no big deal, but we're starting to see this higher risk patient. And so these METs, as I said, the chronically sun-exposed areas, relatively indolent behavior, low metastatic rate, but occurring more and more in this higher risk group. BCC, you know, these are pretty classic, pretty common. Rising in sun-damaged skin, rarely on palms and soles. 4 major types, nodular, superficial, morphiiform, and fibroepithelial. There can be a combination lesion. Some of them have squamous components, and some of them are pigmented because they occur in darker skin. This is pretty classic. I mean, I think anybody can pick this sort of stuff up by that eyelid. You know, that rolled, pearly border with some crusting in the middle, usually some telangiectasias around it. They can ulcerate, no big deal. Again, nodular basal cell carcinoma, looking at the edges. It's hard to misdiagnose these. And as I said, some of them do have features of both basal cell and squamous cell carcinoma, which is no big surprise. Basal squamous is a little bit more likely to be metastatic in a higher risk group. And then micronodular BCC tend to be more destructive. They certainly have a higher rate of recurrence, and they have potential metastases as well. So we're also starting to see basal cell carcinoma a little bit more in younger people. The youngest patient I've done Mohs on is a 14-year-old boy. And it's interesting, I treated him probably 25 years ago. I've seen him now, you know, he's 40-something, he has kids. He never had another lesion, but he had a biopsy-proven basal cell carcinoma. Superficial BCC, often misdiagnosed. So here's, you know, back to the, you know, what's a differential diagnosis? I mean, looks like psoriasis, looks like eczematous dermatitis. Well circumscribed, macules or patches, usually has some focal scale, some crusting, tends to occur in some of the younger people. And trunk and extremities here are the more common locations and not the face. Morphiiform is the more destructive version. These tend to have a high recurrence rate unless they're treated with techniques like Mohs surgery. It certainly is a less common subtype. We see it a lot because we do Mohs, but not necessarily the most common version. It looks almost like a scar sometimes, or a plaque of morphea or localized scleroderma. But there are telangiectasias on the side, and they are more destructive. And you can see that cheek there on the right. It would be very easy to misdiagnose that as a scar because it really looks like a scar, and in fact, it is a morphiiform basal cell carcinoma. As I said, metastases from BCC are really rare. You know, anywhere from 1 to 1,000, and I think that is inaccurate. I think it's even rarer than that, to 1 in 35,000, and it's more of a lymph node metastatic spread. So we've got lots of different approaches to treatment of these, everything from Mohs surgery, other destructive techniques, DNC, cryotherapy, superficial radiation therapy, which I'll talk about later, which was in vogue in the 1980s, disappeared, and has really come back big time in the last 10 years. And those of us who do a lot of cutaneous oncology tend to do both Mohs and SRT. Some of the more difficult basal cell carcinomas, you know, there are now techniques and approaches available that did not exist 15 years ago. And this is the oral hedgehog pathway inhibitors, vismodegib and sunitinib. This is the Genentech product and the Sun Pharmaceutical product. These are oral agents for more difficult and progressive basal cell carcinoma. And then difficult squamous cell carcinoma, again, you'll hear about that. PD-1 inhibitors, cemiplimab, which is used for difficult squamous cell carcinoma or difficult basal cell carcinoma, unresponsive to hedgehog pathway inhibitors. So that's it for the differential diagnosis.